Hey everyone, welcome back for another deep dive. Today we're tackling a condition that should be very familiar to all of you, septic arthritis.
Yes, definitely an important one to cover.
We'll be focusing on the World Health Organization's AWARE book and taking a deep dive into their chapter on septic arthritis, focusing on diagnosis, treatment, and antibiotic choices.
Oh, that's good.
So this deep dive is geared towards medical microbiologists like yourselves. So think of this as a focused refresher, or maybe even some material you could use for your next presentation.
Excellent.
So to kind of set the stage here, let's say you have a patient coming in complaining of intense joint pain, swelling redness.
Right.
And this all come on suddenly.
Yeah.
Affected joint is hot to the touch. So what's going on here?
Well, this is a pretty classic presentation of septic arthritis.
Okay.
It's an infection that settles right into the joint space.
Okay.
Now, it's not always as straightforward as, one bug, one joint.
Right.
We have to consider whether it's gonococcal or non-gonococcal. What type of joint is affected, and if there's any bone involvement, pointing towards osteomyelitis.
So right away, we're already thinking about, different scenarios.
Absolutely.
Potential complications.
Yeah.
And of course, we can't forget about those individual risk factors.
Right.
That can really shape the clinical picture.
For sure.
Right.
Yeah, things like a recent penetrating injury, history of intravenous drug use, underlying conditions like rheumatoid arthritis.
Yeah.
These can significantly increase a patient's susceptibility to septic arthritis.
It really sounds like a detective case.
It is.
Yeah. Piecing together the clues to figure out who the culprit is.
Absolutely.
And how they managed to, break into the joint.
Love that analogy.
So speaking of culprits, let's talk about the usual suspects.
Okay.
In adults, we have Staphylococcus aureus, including MRSA.
Right.
Is a major player, along with other staph and strep species.
Yes.
But then things shift a bit when we look at our pediatric patients.
Right. Yeah, for sure.
Yeah.
So while Staph aureus remains a top contender in children, we also need to consider Streptococcus pyogenes, Kingella kingae,
Okay.
and Haemophilus influenza type B,
Okay.
particularly in younger age groups.
Yeah.
And don't forget about invasive non-typhoidal salmonella,
Right.
which can also cause septic arthritis in children.
Okay. So we have our list of suspects.
Yep.
But how do we actually confirm their involvement?
Right.
What lab tests are we going to order to nail down this diagnosis?
Well, synovial fluid analysis is our bread and butter here.
Okay.
We're looking at the white blood cell count, which will be significantly elevated in septic arthritis.
Right.
And we'll send the fluid for both microscopy and culture.
Okay.
Now, ideally, we want to collect these samples before starting antibiotics.
Right.
To get a clear picture of what we're dealing with.
But of course, we have to balance that with the urgency of treatment. Right.
Exactly.
Yeah.
The WHO AWARE guidelines actually highlight that early intervention is key to preventing joint damage, especially in children.
Right.
So sometimes we have to make those treatment decisions based on clinical suspicion while we wait for those crucial microbiology results.
Yeah, you got to make the call sometimes.
Yeah.
So speaking of microbiology, are there any specific techniques or considerations for culturing those synovial fluid samples?
Well, we need to consider the fastidious nature of some of these organisms.
Well,
Kingella kingae, for example, can be tricky to grow.
right.
So using appropriate culture media and incubation conditions is key.
Okay.
Blood cultures are also important, especially if we suspect the infection has spread beyond the joint.
So it's not just about collecting the sample, but it's also about handling it correctly to make sure we're not missing those sneaky pathogens.
Exactly.
Now, while we're waiting for those cultures to grow, are there any other lab tests that can help us gather more information?
Yes, the inflammatory markers are particularly helpful. Things like C-reactive protein, erythrocyte sedimentation rate, and procalcitonin.
Right.
They give us a good indication of the severity of the inflammation.
So it's like building a case layer by layer,
Absolutely.
using all the evidence we can gather.
Yeah, and speaking of getting a visual, we can't forget about imaging.
Right. Because sometimes a picture is worth 1,000 lab tests.
Yes.
So what are our go-to imaging modalities for septic arthritis?
Ultrasound is often our first choice.
Okay.
It's readily available, doesn't involve radiation, and it's excellent for visualizing joint effusions
Right.
and synovial thickening.
Yeah, those telltale signs of inflammation.
Exactly.
So what about MRI? When do we use that?
However, if we're concerned about bone involvement or complications like osteomyelitis, an MRI might be needed.
So ultrasound for that initial assessment.
Yep.
And MRI when we need a more detailed look.
Precisely.
Okay, so once we've confirmed the diagnosis, what are our key steps in managing septic arthritis?
Well, the cornerstones of treatment are prompt surgical drainage and lavage of the joint and appropriate antibiotic therapy.
So it's not just about pills. There's a surgical element as well.
Absolutely. Source control is paramount in septic arthritis.
Okay.
Surgical intervention allows us to remove that infected fluid and debris, giving those antibiotics a fighting chance to work.
And speaking of antibiotics, let's dive into the arsenal.
Right.
What are our go-to weapons for combating septic arthritis?
Okay, so ideally we want to use targeted therapy based on the microbiology results.
Right.
But in those urgent situations where we can't wait, empiric treatment is crucial.
Right.
And here's where the WHO AWARE guidelines really come in handy.
Okay.
They provide clear recommendations for both empiric and targeted antibiotic choices,
Excellent.
along with specific dosage information.
So it's like having a roadmap
It is.
guiding us through those critical treatment decisions.
Exactly.
So for adults, our first-line empiric choice is usually intravenous cloxacillin, right, targeting those staph and strep species.
Yeah.
Now, for our younger patients, I bet it gets a bit more nuanced.
Oh, for sure. Kids are not just small adults.
No, they're not.
Absolutely not.
Yeah.
So we still start with intravenous cloxacillin for children,
Okay.
but we often add an oral dose as well.
So,
And here's a crucial point. We need to cover Enterobacterales empirically in neonates,
okay.
usually with cefotaxime or ceftriaxone.
Okay. So we've got our empiric choices down.
Yep.
But what if cloxacillin isn't an option, say, due to allergies or resistance concerns?
Right.
What are our alternatives?
Well, the AWARE guidelines offer a range of alternative options, including amoxicillin clavulinate, cefazolin, cefotaxime, or ceftriaxone,
Go.
all given intravenously.
Mm-hmm.
We might also consider clindamycin, which can be given both intravenously and orally.
Okay.
Of course, the specific choice and dosage will depend on the patient's individual circumstances, and that's where clinical judgment comes into play.
Right. Okay, so we have this arsenal of antibiotics.
Right.
But how long does this antimicrobial battle usually last?
Well, treatment duration can vary, but for children, we're typically looking at around 3 weeks of antibiotics.
Okay.
For adults, it's usually longer, around 4 to 6 weeks.
Okay, so we've covered the who, the how, and the what of antibiotic treatment.
Yeah.
But before we move on, I want to rewind a bit
Yeah.
and ask, how does this infection actually take root in the joint?
So imagine this. Bacteria are circulating in the bloodstream, and suddenly they encounter a vulnerable joint, perhaps one that's been weakened by injury or inflammation.
Okay.
They latch on, infiltrate the synovial membrane, and start multiplying within the joint space.
So it's like a hostile takeover.
Exactly.
Right.
And once they've established a foothold, they trigger a cascade of inflammatory responses leading to the pain, swelling, and joint damage we see clinically.
So it's not just the bacteria themselves causing trouble, it's the body's own immune response adding fuel to the fire.
Exactly. And this highlights why prompt diagnosis and treatment are so crucial.
Right.
The longer the infection and inflammation persist, the greater the risk of long-term joint damage.
That makes perfect sense.
Yeah.
Now let's zoom out a bit and talk about the bigger picture.
Okay.
How common is septic arthritis?
Right.
And who should we be particularly watchful for?
Well, while septic arthritis isn't exactly a common cold, it's definitely something we need to be aware of, especially in certain patient populations.
Right.
People with weakened immune systems, those with underlying joint conditions like rheumatoid arthritis,
Okay.
and individuals with prosthetic joints are all at increased risk.
So those are the folks we need to be extra vigilant about.
Yes.
Looking for those early signs and symptoms so we can intervene quickly.
For sure.
Now, before we move on to the next chapter of our deep dive, I have a little pop quiz for you.
Okay, bring it on.
You ready to test your knowledge?
I think so.
All right.
Let's do it. Okay, so first question. What are the 3 main ways bacteria can reach the joint space?
3 ways, huh?
Think back to our discussion about how the infection takes hold.
So we talked about bacteria traveling through the bloodstream, which seems like the most common route. Then there's the possibility of them sneaking in from a nearby infection.
Right. Yeah.
And finally, there's direct inoculation, maybe through an injury or surgery.
Yes.
So those are my 3 guesses. Bloodstream, local spread, and direct inoculation.
You got it.
All right.
3 for 3, right out of the gate. All right, next question. What's the most common pathogen causing septic arthritis in both children and adults?
Okay, this one's a bit of a no-brainer, right? We've
Yeah.
mentioned it a few times already. It's Staphylococcus aureus, including those pesky MRSA strains.
Yeah, I got it.
All right, 2 for 2.
Let's see if you can keep this streak going.
Okay.
What imaging technique is typically preferred for the initial evaluation of suspected septic arthritis?
Right. Think back to our imaging discussion. We want something that's readily available, cost-effective,
Right.
and gives us a good look at the joint. So that would be ultrasound.
Yes, ultrasound is indeed our go-to for that initial assessment.
Okay.
Now, here's a true or false question for you. Antibiotic treatment alone is usually enough to manage septic arthritis.
This one's a bit trickier.
Okay.
We talked about the importance of source control
Mm-hmm.
and how surgical drainage plays a crucial role.
Right.
So my gut feeling is that antibiotics alone aren't enough. I'm going with false.
You are absolutely right. Surgical intervention in conjunction with antibiotics is essential for successful treatment.
Okay.
All right, one last question to see if you can make it a perfect score.
Okay.
What's the typical duration of antibiotic treatment for septic arthritis in adults?
Okay, we talked about this earlier. For adults, it's usually a longer course, somewhere around 4 to 6 weeks, right?
5 for 5. You aced the quiz.
Oh.
Clearly, you've been paying attention.
We'll have to give credit where credit is due. That WHO Aware book is a fantastic resource. It's like having a cheat sheet for all things septic arthritis.
This is a great resource.
But speaking of cheating,
Uh-oh.
I have a confession to make. I actually peeked ahead in the next section.
Okay.
And I'm dying to know more about those rare and unusual pathogens
Yes.
that can cause septic arthritis.
This is my favorite part.
So spill the beans.
Right.
What are some of the more exotic microbes that can cause trouble in the joints?
Well, as you know, our immune system does an amazing job of keeping those microbial invaders at bay.
Right.
But in patients who are immunocompromised, perhaps due to HIV, chemotherapy, or certain medications, we have to widen our scope.
So we're talking about opportunistic infections, those that seize the opportunity when the immune system is weakened.
Exactly. And in these cases, we might see fungi like Candida species
Okay.
or Cryptococcus neoformans causing septic arthritis. These are usually organisms we associate with other types of infections, so seeing them in the joints can be a real curveball.
So it's like those fungi see an opening and decide to take advantage of this situation.
Yeah, they're very opportunistic.
It makes you realize that we can't afford to have tunnel vision when it comes to infectious diseases.
Absolutely. We need to keep an open mind and consider the broader possibilities, especially when dealing with immunocompromised patients.
And what about mycobacteria?
Yes.
They're known for causing trouble in the lungs,
Right.
but can they also target the joints?
You're right. Mycobacterium tuberculosis, the culprit behind tuberculosis, can also cause a type of septic arthritis called tuberculous arthritis.
So it's not just about those quick-hitting bacterial infections. We can also have these more chronic, insidious cases.
Precisely and clinically, tuberculous arthritis often presents differently from typical bacterial septic arthritis.
Okay.
The onset is usually more gradual, and the symptoms might be more subtle.
So we need to have our diagnostic antenna up,
Yes,
looking for those less obvious presentations.
exactly. A high index of suspicion is crucial, especially when a patient presents with persistent joint pain and swelling that doesn't respond to the usual treatments.
Right.
We might need to consider special staining techniques or molecular methods like PCR to detect those sneaky mycobacteria.
So it's like a whole different level of detective work using those advanced techniques to track down those elusive pathogens.
Precisely. And this brings us to another important point. We've been focusing on identifying the specific pathogen, but we also need to consider its susceptibility to different antibiotics.
Right, because not all antibiotics are created equal, and we're facing that ever-growing challenge of antibiotic resistance.
Exactly. And this is where those AWARE guidelines are so valuable.
Good.
They don't just tell us which antibiotics to use,
Right.
they also provide guidance on dosages, routes of administration,
Okay,
and
fine.
duration of treatment, all tailored to specific pathogens.
It's like having a customized treatment plan taking into account the bug's weaknesses and the patient's individual circumstances.
That's a great way to put it. And it's this personalized approach that's key to optimizing treatment outcomes and minimizing the risk of complications.
Speaking of complications, we talked about the potential for joint damage.
Right.
Are there any other long-term consequences we need to be aware of?
Well, chronic pain and stiffness are definitely major concerns, especially if the infection isn't caught and treated early.
Right.
And in some cases, septic arthritis can even lead to disability, limiting a person's ability to move and perform daily activities.
So it's not just about getting rid of the infection, it's about preserving joint function and quality of life.
Absolutely. And this highlights the importance of a comprehensive approach to management.
Right.
Involving not just antibiotics and surgery, but also physical therapy and pain management strategies.
So it's a team effort with different specialists working together to provide the best possible care for the patient.
Exactly.
Now, before we wrap up our deep dive, I want to circle back to something you mentioned earlier. Prosthetic joint infections.
Yes.
You said they present a unique challenge.
They certainly, you see, when a prosthetic joint gets infected, it's like bacteria hitting the jackpot.
How so?
They have this wonderful non-living surface to cling to, and they form these incredibly resilient communities called biofilms.
Biofilms, those are like bacterial cities, right?
Yeah.
I imagine them as these slimy fortresses shielding the bacteria from antibiotics and immune cells.
That's an excellent analogy.
Yeah.
These biofilms make treating prosthetic joint infections incredibly challenging.
I bet.
Antibiotics have a hard time penetrating those slimy barriers, and the bacteria within the biofilm are often much more resistant to treatment.
So it's like trying to break down the walls of a castle.
Exactly. And because of these challenges, managing prosthetic joint infections often requires a multi-stage approach.
Okay.
Yeah.
So it's not just about giving a longer course of antibiotics. We need to physically remove those infected implants and biofilms.
Precisely. The typical approach involves a two-stage revision surgery.
Okay.
First, the infected prosthesis is removed, and the area is meticulously cleaned and debrided. Okay.
A temporary spacer, often loaded with antibiotics, is then implanted to keep the joint space open and deliver those antimicrobial agents directly to the site.
So it's like hitting the reset button, giving the body a chance to clear the infection before putting in a new implant.
Exactly.
Okay.
And after a course of intravenous antibiotics, typically for several weeks, a second surgery is performed to implant the new prosthesis.
So it's a long road for the patient, but those extra steps are often necessary to ensure a successful outcome.
Absolutely. Prosthetic joint infections are complex and require a multidisciplinary approach.
For sure.
Involving orthopedic surgeons, infectious disease specialists, microbiologists, and of course the patient themselves.
Right. It's a reminder that treating infections is rarely a solo mission.
Right.
It requires collaboration, expertise,
Yes.
and a deep understanding of both microbiology and the clinical aspects of the disease.
Well said. And speaking of deep understanding, let's delve even further into the microscopic world of septic arthritis.
We've talked about bacteria entering the joint, but I want to zoom in on the actual battle that takes place between those microbial invaders and the body's defense systems.
All right.
It's a fascinating and complex dance of molecular warfare.
Okay, I'm ready to put on my metaphorical lab coat and grab my imaginary microscope. Let's explore this microscopic battlefield. Okay, so we're suited up and ready for our microscopic adventure into the world of septic arthritis. Set the scene for us. What's happening at that cellular level when bacteria invades a joint?
So picture this a bacterial cell. Let's say our old friend Staphylococcus aureus manages to breach the joint's defenses and finds itself surrounded by synovial fluid. Now you might think this is a welcoming environment, rich in nutrients, but it's actually a hostile battleground.
So not exactly a friendly welcome party for those bacterial invaders.
Not at all. The synovial fluid is teeming with immune cells, like neutrophils and macrophages, ready to engulf and destroy those unwelcome guests. But S. aureus is a wily opponent. It has a whole arsenal of virulence factors, molecular weapons that allow it to survive and even thrive in this hostile environment.
Virulence factors. Those are the bacterial superpowers, right?
Exactly.
What kind of tricks does S. aureus have up its sleeves?
One of its key weapons is the ability to adhere, to literally stick itself to the articular cartilage. It does this using adhesins, molecules on its surface that act like grappling hooks, binding specifically to components of the cartilage matrix.
So it's not just floating around aimlessly, it's actively attaching itself, gaining a foothold in the joint.
Exactly. And once it's attached, it can start multiplying, forming microcolonies that further strengthen its grip. But it doesn't stop there. S. aureus also releases a barrage of toxins and enzymes that directly damage the cartilage, contributing to the breakdown and erosion we see in septic arthritis.
So it's a double whammy: physical damage from the attachment and chemical warfare from those toxins and enzymes. No wonder patients experience so much pain and inflammation.
Precisely. And to make matters worse, this bacterial assault triggers a massive inflammatory response. The immune system sends in reinforcements, flooding the joint with even more immune cells.
So the cavalry arrives, ready to fight those bacterial invaders.
That's the idea, but unfortunately, this immune response can be a double-edged sword. While those immune cells are meant to protect us, their excessive activation can actually contribute to further damage.
It's like friendly fire, the immune system trying to help, but ending up causing more harm.
That's a great way to put it. And this uncontrolled inflammation plays a major role in the cartilage destruction that can lead to long-term disability in patients with septic arthritis.
So it's a race against time to control both the infection and the inflammation.
Absolutely. That's why prompt surgical drainage and lavage are so crucial. They physically remove the bacteria and those inflammatory mediators, giving the antibiotics a chance to work more effectively.
It's like clearing the battlefield, creating a more favorable environment for those antimicrobial agents to do their job.
Exactly. Now let's shift gears a bit and talk about the role of the WHO's AWARE guidelines in all of this. We've mentioned them throughout our discussion. But how do they actually translate into real-world practice?
Yeah, that's a great question. It's one thing to have these guidelines, but how do they actually guide our decisions at the bedside?
Well, the AWARE guidelines provide a framework for decision-making, a roadmap for choosing the right antibiotics and determining the appropriate dosage and duration of treatment. But ultimately, it's up to the individual clinician to tailor those recommendations to the specific patient.
So it's not a one-size-fits-all approach. We need to consider the patient's age, overall health, allergies, and the suspected pathogen, right?
Exactly. And we also need to be vigilant for signs of improvement, such as decreased pain and swelling, as well as potential complications like antibiotic resistance or allergic reactions. It's about monitoring the patient closely and adjusting the treatment plan as needed.
Speaking of antibiotic resistance, that's a global challenge we can't ignore. How do the AWARE guidelines address this issue?
Well, the AWARE program places a strong emphasis on antimicrobial stewardship, which means using antibiotics wisely and only when necessary. The guidelines promote targeted therapy whenever possible, based on those microbiology results we talked about, to minimize the use of broad-spectrum antibiotics, which can fuel resistance.
So it's about choosing the right weapon for the right battle, avoiding that overkill approach that can backfire in the long run.
Precisely. And it's also about educating patients on the importance of completing their full course of antibiotics, even if they start feeling better before the course is finished.
Right, to prevent those straggler bacteria from developing resistance and coming back with a vengeance.
Exactly. And on that note, I think we've covered a lot of ground today. We've journeyed from the macroscopic world of swollen joints to the microscopic battlefield of bacteria and immune cells.
It's been a true deep dive exploring the complexities of septic arthritis from multiple angles.
And I hope our listeners have gained a renewed appreciation for the importance of collaboration, vigilance, and a solid understanding of both the microbiology and the clinical aspects of this fascinating condition.
Well, I think it's safe to say mission accomplished. We've armed our listeners with the knowledge and resources they need to tackle septic arthritis head-on.
Absolutely.
So to all of you out there, keep those microscopes focused and those minds curious. The world of microbiology is full of surprises, and who knows what fascinating deep dive awaits us next. Until then, stay well and keep those lab coats clean.